Hello, this is Garret Choby, and today we'll be discussing a case of a combined external transmaxillary as well as an endoscopic transpterygoid approach for resection of V2 through foramen rotundum. As you can see in this case, this is a patient with a cutaneous skin malignancy with involvement of the infraorbital nerve and tracking back towards foramen rotundum. This is a multidisciplinary case involving my colleagues in head and neck surgery, facial plastic surgery, and Dr. Van Gumpel in neurosurgery. Here is a coronal T1 post-GAD MRI scan demonstrating hyperintensity of the infraorbital nerve. As you can see here, the primary malignancy has been resected, and here we are working on the infraorbital nerve as it exits into the soft tissue of the skin. We will mobilize that from the skin defect directly into the maxillary sinus in a transmaxillary approach. And here we are endoscopically through the face of the maxillary sinus, dissecting out the infraorbital nerve along the orbital floor, ensuring that we are resecting the nerve as well as the associated periosteum and soft tissue of the infraorbital canal. We'll go ahead and mobilize the mucosa around it and bring that with us as well. Once we've resected this back towards the pterygopalatine fossa, we'll then go endonasally and perform a left-sided maxillary enterostomy, as you can see here, with an uncinectomy, and then addressing the ethmoid bulla and doing our ethmoid sinus work through this area. Once we've opened up the total ethmoids as well as the sphenoid sinus, you can see here, we'll then look towards the retromaxillary space and open that area up widely in order to visualize well the edge of the pterygopalatine fossa. Here we are removing the left middle turbinate, as you can see here, pulling that away from the skull base to ensure we don't have an inadvertent CSF leak in that area. And here we are identifying the sphenopalatine foramen from the pterygopalatine fossa into the nasal cavity as we perform our transpterygoid approach. Utilizing a Carlson rongeur, we'll open up into the sphenopalatine foramen, ensuring we keep the periosteum of the pterygopalatine fossa intact, as we dissect out just over top of the sphenopalatine artery, as you're beginning to see visualized there. We continue to take down the bone of the posterior aspect of the maxillary sinus, exposing the pterygopalatine fossa. And again, you see a little bit of bleeding here from the artery, which we'll take care of with bipolar cautery here. We'll continue to open this area up more laterally, as you can see here, exposing the soft tissue of the pterygopalatine fossa, as it contains things like V2, the sphenopalatine artery, as well as the pterygopalatine ganglion. Here we are using a bipolar just to take care of a small branch of the artery as we dissect that area to visualize that area a bit better. Here we are turning our attention back to the orbital floor and dissecting out that nerve as it goes back towards the pterygopalatine fossa. Removing some bone of the infraorbital canal, as you can see there, and then taking care of some mucosa on either side with a bipolar cautery, and trimming back that soft tissue to resect this nerve en bloc. Here that nerve has been mobilized into the nasal cavity, and here we are working just a bit posteriorly and high as we're opening up the rest of the pterygopalatine fossa towards foramen rotundum. Once we've identified that, we begin to drill over top of foramen rotundum to expose this area back towards Meckel's cave. Meticulous drilling here over top of the foramen rotundum is really important, and here you can see us mobilizing the area between the Vidian nerve as well as V2 as it tracks back towards rotundum. Here we are drilling out that bone of the pterygoid wedge between the two, between the Vidian nerve and foramen rotundum. You can see a bit of bleeding there from the artery, the pterygoid canal, or the Vidian artery. So we'll go ahead and address that with bipolar cautery here as we continue to drill and remove bone here. This exposure allows us to retract the contents of the pterygopalatine fossa inferiorly and laterally and better expose the foramen rotundum as it works back towards Meckel's cave. Once we've exposed V2 this area, as you can see, we're dissecting out the nerve here through foramen rotundum and the entirety of the soft tissue and periosteum around it. And as it gets into Meckel's cave here, we'll go ahead and bipolar it and transect it to remove the entirety of it from the infraorbital nerve of the soft tooth of the cheek through foramen rotundum in an en bloc fashion. Here we are removing the last bit of the nerve there in foramen rotundum and dissecting out the last bit of that soft tissue component at the junction of rotundum and Meckel's cave, as you can see right about there. Then here the last bit of the nerve is being mobilized, and you'll see us take out the entirety of the length of the nerve here on an en-bloc fashion through the nasal cavity. This is just mobilizing it from the pterygopalatine fossa, the pterygopalatine ganglion, and then here the whole specimen is coming out of the nose. And then finally what you'll see here is that nerve was pathologically involved, but here we're taking our final margin of the nerve at the junction of Meckel's cave, as you can see here. Take that final margin and then bipolar the remaining portion of things there. The pterygopalatine fossa is, of course, quite vascular as the SPA comes to that region, so we're getting a little additional hemostasis here at the end of the case. Afterwards, we harvested a free mucosal graft and did place it as reconstruction over top of the exposed foramen rotundum, and you can see that dissection in a separately recorded video. Finally, when resecting the infraorbital nerve in V2 for involvement from a cutaneous malignancy, it's important that you approach this to resect the entirety of the nerve from a transfacial approach as well as an endoscopic endonasal approach, oftentimes utilizing a transpterygoid adjunct. It's important to take the entirety of the nerve as well as the soft tissue surrounding it, including the periosteum, as part of your specimen. And lastly, always know the purpose of your operation. If you're simply doing this to track the nerve for margin status and for radiation therapy, know what your stopping point is. Are you going to stop at pterygopalatine fossa or track it the whole way back through Meckel's cave? Understanding that ahead of time will be really important for planning your surgery.